at my hair. Look at the way they did my hair.
You just did that, Rose.
Go to hell.
All right, Rose.
Well, don't fight, Rose.
Well,
There are many words for the behavior we see: acting out, disruptive, combative, agitated, aggressive. Aggression is regularly directed at staff, often during personal care. But aggression also erupts between residents.
Don't scratch me again.
Don't mess in here. She and I are playing, not you.
If you got a temper, that means you
Oh,
got to make
come on, will you?
Shut up!
That's not mine. I didn't do.
Sometimes agitated, aggressive behavior becomes so troubling that outside help is sought. Admission of older adults to psychiatric inpatient units has become increasingly common as nursing facilities search for solutions to aggressive behavior. But as the case of Mrs. L reveals, aggressive behavior among older adults is often difficult to assess and treat, the result of multiple factors, and often is perceived differently by patients, nursing home personnel, inpatient staff, and family members.
Mrs. L has been here, it's now April. Mrs. L has been here since February. Initially, we were pretty puzzled why she was here because we weren't seeing the aggressive behavior that the nursing home had complained about and why they had sent her to us.
Mrs. L's granddaughter and great-grandson, her closest family members, met with the inpatient team to discuss problems that led to Mrs. L's admission.
In the lunchroom one day, someone was taking food off of her plate, so she slapped them on the arm. I probably would have done the same thing. She does not like people in her space. She doesn't want to be confronted.
Okay.
I think it's normal.
This doesn't sound too outrageous to me, but what is there anything else besides that one incident?
The last incident was her pulling the resident's hair, supposedly unprovoked.
I was curious to hear what you had heard from the nursing home staff, because you've been our contact person with them, John. And,
Well, the way they described it was pretty much that these random incidents, especially what really concerned them was the hair pulling. They were very concerned about that. And it seemed to be unprovoked from their point of view.
Sometimes when people are down in the dumps, they're a little more edgy, and they're a little more likely to respond with hostility to admittedly provocative things. One of the areas that we want to focus on is how your spirits are and see if we can kind of help you with that.
I don't like because I took my cigarettes away.
Really? Where? You mean where? Down there at St. Anthony's, or where?
Here.
Here? You never had any cigarettes here?
No. Because I took them away.
Okay. And you're pretty upset about that. Yeah. How long have you smoked?
Seems like all my life.
It's bad for your health. It's bad for your health. Smoking.
Oh. I'm 80 what?
9.
That's old enough. I might as well enjoy the last few years.
Yeah. What
So
kind of
what's-
medication is she on now?
She's on Paxil, which is an antidepressant, and Depakote, which is a mood stabilizer.
We also added pain medication because she seemed to be most angry and most aggravated when getting out of bed in the morning, and she'd complain about back pains. So we thought if we gave her some pain medication before she got out of bed.
Margaret.
Aggressive behavior may be extremely variable, is triggered by a variety of events, and often is difficult to resolve.
I think that Mrs. L is not that atypical in that the first few weeks that she was here, we didn't see the symptoms that the nursing home was complaining about. But then as she was here for a while and she began to settle in, that's when she started to kind of slide back, and that's when we saw the same behaviors that the nursing home was complaining to us about. that she was aggressive and not able to cooperate. And even if you tried every kind of intervention that you had, she just was not cooperative.
People with dementia, for obvious reasons, start to have trouble articulating their complaints, and so they can't put into words that they are depressed or unhappy or bothered in some way, and they tend to act it out. And we see that time and time again, where they'll throw their tray on the floor or punch somebody because they're angry, unhappy, frightened oftentimes.
By noon, she is very reasonable. She does everything that you could hope for, and she stays with the good behavior for about 16 hours. Throughout the whole evening, the first part of the night, behaviors are perfectly fine. And then in the wee hours of the morning, boom, you're back to the same aggressive kind of behavior that you just had the day before.
We're really conceptualizing the problem as depression superimposed on dementia. So if you treat the depression in the usual way, that is with medication, ECT, psychotherapy if it's appropriate and possible, family therapy. If you do that, the agitation goes away, and so does the apparent distress that the patient seems to experience.
Movement between levels of care, even when the person seems stable, may trigger additional problems for a variety of reasons. Behaviors may erupt again because of environmental changes, or because medications are reduced or discontinued. In other cases, no clear reason can be identified.
I think our challenge is going to be transferring what experience we've had here with your grandmother to the folks at St. Anthony's. And obviously we have a different facility, we've got different staffing, so we can't just assume that they can carry out exactly what we're doing here.
We'll get a patient back that we discharge to a nursing home, and when they come back, they're on different meds, less meds. Something has definitely changed about their medication regime. We don't hear why that has happened. And it's pretty frustrating for us because we've worked very diligently at finding the right med, the right dosage, feel like we have everything under control, discharge them thinking that that's going to stay that way, and then to see them a month later and their medications have been changed, it's very frustrating.
Stand up for me, okay?
Get away from me. Get away from me.
Listen.
Get away from me.
The issues and challenges that many nursing home personnel face are highlighted in the care and treatment of Rose, a resident who was recently transferred to the nursing facility from a psychiatric unit.
We attempted to use multiple medications to control her behavior, and to be honest, we just ran into one side effect after the other. First we had her very listless and sleepy, and then another time we had her very tremulous and shaky. And then we got her at a point where we thought the side effects were tolerable and the behavior was moderately controlled, and she moved here, and as soon as she stepped on the unit, everything seemed to break down.
Right.
Caused a lot of distress for the staff, a lot of distress for the family, and you don't think she's too comfortable in that state. Actually, what seemed to work best for Rose was to give her the choice of what activity she wanted to participate in, and not to push the issue. And when Rose gets agitated, we know the thing that works best for her is what?
Bed rest.
Rose, do you want to go back to bed?
Yeah, take me to the bedroom. Wherever they, I don't know where they take you.
And it took us a while of observing her behaviors to see what the trigger was, but every time we forced her to sit up in a wheelchair, she got agitated.
She'd start yelling, spitting, throwing things.
Go to hell.
Don't kick. Come on. Let's go over here and sit by the window.
Go to hell.
Do you want to go to bed?
Go to hell.
We're going to have some lunch.
Go to hell. You big fat slob, you. Big fat slob.
Go to hell.
You know, you can argue, well, putting her in bed, is that the kind of outcome you really want, because you want people up and participating and interacting, but as the disease progresses, I think the goals of our treatment change, and also patients' abilities to make decisions diminish, and the definition of autonomy, I think, changes. And for Rose, that was an autonomous wish. She wants to be in bed.
And actually, she's much happier, and she does say when she wants to get up and when she doesn't want to get up, and she seems to be fine. Right. She takes her medications. We don't have the acting out problems that we had beforehand.
God, this.
You want your pie?
I don't want any more.
No more?
No. Just take everything off. Please.
Okay.
Have you got a handkerchief or a
what
wet
handkerchief?
cloth? Or...
Here.
Thank you so much.
You're welcome.
And in the way they approach the residents, I think is unique. Their tolerance for behaviors, the way they kind of look at the individual who's exhibiting the behavior, not necessarily reaching for a phone and calling me to say, gee, we need to medicate this patient, but trying to take a few steps back and say, gee, what triggered this? What got this individual upset? And is there a way around it? Is there a way to make him more comfortable with his environment? It's almost as though the behavior is a sense of shared responsibility, because one of the biggest precipitants of nursing home placement for dementia is agitated behavior and behavioral problems. Rose, in kind of my book of patients, was one of my most challenging patients, and she's quiet here most of the day. And what it's done for me is it's actually forced me to rethink my approach to treating behavioral issues. I'm less anxious to reach, and write a prescription or over the phone say, well, start this medication. I'm much more interested in, well, what was the trigger of the behavior? Are there any other changes you noted? Does this behavior represent an underlying physical problem, or is he just having a bad day?
What are you taking it off? Don't take it off. Hey, you better put clothes on. All right, we'll tell them what to do. Oh, yeah, wait.
Aggression during personal care is common and often is related to touch or invasion of personal space, frustration, pain, loss of control, inattention to personal needs, and fear of the unknown.
The more you know the resident, the better you're able to facilitate their needs. And if you have floating staff or changing staff on a consistent basis, you never build that rapport, you never get that safe feeling.
If a person really knows that resident, they can read even the smallest behavior and realize when they're building toward maybe a catastrophic episode, and they can stop it right there. If you have somebody that's a stranger to that person, they're not going to know the cues.
And if you really look at every behavior as a message telling you something, that's the way you can become a detective and maybe get some of those behaviors to diminish.
Linda is bathing Margaret here for the first time. She is focused on the task, getting Margaret bathed and dressed, rather than on Margaret, the person, who is uncomfortable and dislikes being done to. Margaret responds by becoming more and more agitated and upset.
Okay. You go all the way with her. Get here,
Margaret, you're cold, aren't you? Let's put your blouse on.
Oh, I did not.
It's cold outside.
No,
let's put this on. Come on, let's put this on.
Sometimes we try and work from logic, and they're not able to think logically through a situation. So we're asking them to respond in a manner that they're not able to respond to. And so then our frustration builds, and they read into that. So then their frustration builds, and the situation escalates, rather than us trying to follow their cue. I think that's a real good way to care for somebody, is to really follow their lead. They're going to let you know what they're feeling, thinking, what they want to do and what they don't want to do. And listen to them, because when they say no, usually they mean no.
So just to keep telling her what's going on. You know, Margaret, I'm putting your sock on, just so she knows, right?
Nurse specialist Ana Ortegara talks with staff about Margaret. Together, they think of ways to help Margaret be more comfortable, like giving her choices, respecting her privacy needs, focusing on her as a person, not just the task, using a calm, personal, gentle manner, taking time, not rushing, and explaining what is being done.
What I'd like to ask you about is, what are the things we could try to help Margaret be more successful in a bath? What are some of the things you might want to talk about with her once you get to the shower?
Well, maybe tell her, you know, that she's going to help me. We're going to give her a shower and maybe go out somewhere. Someone's going to pick her up, and, you know, maybe she'll be glad that someone's coming to pick her up.
I like that. Linda, that's a good idea.
Okay, I'll give you one for you, okay?
Irene applies these techniques during Margaret's next bath. She constantly interacts with Margaret, talking to her in a soothing voice and following her cues.
You nice. You clean, I'm clean too. Yes. What's your name, sister? You remember? Yeah. What's your name, Francis? Yeah. Oh, good. You like sister? You like sister? Yeah, oh, okay. Sister maybe like you too.
When you push them too far, that's when you get the reactions. So the more you push, the worse the situation gets. And what I've found is, in all the years I've worked with it, the more you pull back and give them control of the situation, the better it gets.
Okay, you have to turn around.
You have to turn around.
Yeah, you have to turn around. Turn your bottom the other way. We're going to sit on the toilet, okay? We're going to sit on the toilet. Turn around.
Mo used to strike out on a regular basis, and still does when he is pushed. Over time, staff learned that slowing down, breaking chores into smaller steps, cueing, and being patient and reassuring reduced the risk that Mo would strike out.
How does this feel? Dry?
Getting dry.
Okay, getting dry. Slowly but surely. Okay, Mo. Next, you have to wash your... You have to wash your private part, okay?
Even the most personal chore, washing personal parts, is now done successfully and without agitation or aggressive episodes.
Good, Mo. And we have this thing called so what? That if they don't want to do it today, so what? If they don't want to bathe today, so what? If they don't want to eat breakfast but just have their orange juice, so what?
Get out of that box and stop with the schedules. Let them dictate what the agenda is going to be for the day.
Are you ready to get up, Mo?
Because you can do this, and you may be able to do it later if they're not going to do it now. It'll eventually get done. And that's where that so what comes in. We talked about the so whats. Nobody ever died from not having a bath today instead of tomorrow, and so forget that Rose needs her bath on Thursday. If she gets half of her bath on Thursday, fine. If she doesn't get any, we'll try Friday. And if she doesn't get it Friday, maybe Saturday will be the day. And getting out of that idea that I have to do it now because that's what the schedule says.
Who's talking there?
Know your goddamn business.
She making my business, damn it.
She should not have to have that. And Gator's classes too.
Dining rooms can be stressful and chaotic, especially for those with dementia. A number of factors may trigger aggression. Noise, confusion, crowding, overstimulation, and competing demands for the residents' attention often create stress and lead to aggression.
Yes, and you were lousy. Very lousy.
Can I be excused?
Asking to be excused is Richard's way of saying he needs to get away from his table mate. The nursing assistant understands the message, and by gently moving Richard to another table, avoids further difficulties. Eating in a calmer, more quiet environment like their room may reduce mealtime behaviors for some residents, or increase them for others.
All right, that's enough!
Can you take care of that at home all by yourself?
Get away from me! Get the hell
Yeah, no, she helped me when we were at home.
I got a cozy mark.
It's our house. I want to live in it. I bought it, and I want to live in it and enjoy it. Yeah.
Well, shut up then.
All right. Oh, she's
Look what this big
For Edith, the background conversation is distracting and upsetting. The many items of food on her tray are overwhelming, and her sister's constant chatter is the final straw.
Oh, leave me alone.
It's so appetizing, like a dead rat. Yeah.
Simplifying the eating environment helps residents be successful, which reduces the risk of frustration and agitation. Developing a calm, quiet, home-like routine is important. The use of tablecloths, flowers, music, lowered lights, and even candles can enhance behavior at meals.
Here's the food and here's the lemonade.
Other adjustments in the social and physical environment in the dining room may include spacing people so each has their own territory, directing and cueing to increase independence, providing assistance only when needed, tolerating messy behavior, and presenting food in a familiar manner. These and other strategies help reduce stress and make mealtime understandable and enjoyable.
Hi, Izzy. Oh. How are you? Fine. Let me help you here, okay? Sure. This is good. Here's a nice milkshake and some chips, okay? And your hamburger.
What is this?
That's a milkshake.
All right, eat that right away?
Sure. Take a drink of that and have a bite of your hamburger.
Appropriate management of aggressive behaviors can lead to a better quality of life for both staff and residents. With support and respect, once agitated and fearful residents can learn how to trust those who are caring for them.
Mo, are you hungry?
No.
No?
No. Don't worry about me.
Okay.
If I want to worry, I know where to go.
You'll come to me if you want someone to worry? Okay.
Not to someone to worry.
Oh.
Someone that could get me out.
Okay.
That's all.
All right.
I know who to depend upon.
You know who to depend upon? Well, that's really good. I'm glad you feel that way.
I do. I absolutely do.
Okay.